Welcome back to the Deep Dive, where we aim to equip you with the essential knowledge and perhaps some surprising insights for your orthopedic practice. Today, we're tackling a condition that can be quite insidious in its onset, but truly devastating for joint health: avascular necrosis. You probably also know it as osteonecrosis. Understanding this properly from its subtle beginnings right through to its major effects, well, it's absolutely crucial for us as orthopedic professionals. And to guide us through the science, the causes, the diagnosis, and patient outcomes, we're very fortunate to have an expert guest with us today. Professor, welcome. It's great to have you.
Thank you. It's a pleasure to be here. Vascular necrosis is certainly a complex challenge, and I'm looking forward to unpacking it with you today. It's definitely a tough one for practitioners and patients alike.
Great. Let's start right at the beginning then. Professor, could you define avascular necrosis precisely for us? And perhaps more importantly, walk us through the core pathophysiological mechanisms that we really need to grasp.
Certainly. So osteonecrosis, at its heart, is a degenerative bone condition. What characterizes it is the death of the cellular components within the bone itself. And this death happens because of an interruption to the subchondral blood supply, the blood flow just beneath the cartilage. Now, you'll hear different names for it: avascular necrosis, aseptic necrosis, sometimes ischemic bone necrosis, but they all fundamentally describe the same thing: bone tissue dying because it's starved of blood.
So the bone tissue is essentially suffocating. What actually happens at that cellular level when the blood supply gets cut off? What's the sequence of events?
That's a good way to put it, yes. When that subchondral blood flow reduces, it creates a state of hypoxia, a severe lack of oxygen within that bone segment. This oxygen deprivation damages the cell membranes, they lose their integrity, and eventually the bone cells, the osteocytes, osteoblasts, marrow cells, they undergo necrosis. They die. Think of it like, well, cutting the power to a crucial part of a city. Things just stop working. The body does try to repair it, but without blood flow, that repair process often fails. Macroscopically, what we then see is subchondral collapse. The bone structure just under the cartilage weakens and gives way, and that collapse inevitably leads to joint degeneration, arthritis, and often severe pain.
Right, and you can actually see evidence of this on imaging, can't you?
Absolutely. On an MRI, for instance, which we'll likely discuss more, you see signs like osteosclerosis, an increased signal on T2 sequences, a decreased signal on T1. These reflect that edema or ischemia in the marrow. You often see these distinctive band-like signals, too, which are quite characteristic.
That paints a very clear picture of the cascade. Where are we most likely to encounter AVN in our day-to-day orthopedic practice? Which joints are the usual suspects?
Okay, so the most common site, without doubt, is the femoral head. The hip is the #1 location overall for AVN. After the hip, we frequently see it in the knee, the talus in the ankle, and the humeral head in the shoulder. These are the major joints we deal with most often. Less commonly, you can get AVN in places like the carpus, the lunate or scaphoid bones in the wrist, or even the jaw. But our main focus tends to be those larger, load-bearing, or highly mobile joints because the functional impact is so significant.
And given that progression to collapse is so detrimental, I imagine early recognition is absolutely key. Is there a critical window we're trying to hit?
Precisely. Early recognition and ideally early treatment are paramount. The aim is always to intervene before significant disease progression, specifically before that subchondral collapse occurs. If we can do that, we stand a much better chance of preserving the joint's viability and function long term. Once collapse happens, treatment options become much more limited, often leading towards joint replacement, and the prognosis, frankly, worsens considerably. The big challenge, of course, is that those early stages are so often silent, symptom-free, making it very hard to catch that window without a high index of suspicion.
It's fascinating that while the basic mechanism, lack of blood flow, is clear, the reasons for that lack of blood flow seem incredibly varied. It's rarely just one thing, is it? Can you elaborate on the risk factors and the theories behind how that vascular supply gets compromised? It sounds like quite a complex picture.
You're spot on. The etiology is indeed a complex puzzle, often multifactorial, which makes pinning down the exact cause tricky in many patients. Shaw and colleagues proposed a helpful framework, grouping the causes into 6 broad categories leading to vascular impairment. It gives us a structured way to think about it.
Okay, what are those categories?
Right. First, there's direct cellular toxicity. This is where something directly damages the bone cells or their environment. Think chemotherapy, radiotherapy, thermal injury, or smoking. Smoking's a big one due to vasoconstriction.
Okay, direct damage. What's next?
Second is extraosseous arterial fracture. This means disruption of the artery outside the bone. So a hip dislocation, stretching or tearing vessels, a femoral neck fracture cutting across the blood supply. Even surgical complications, iatrogenic injury, or rare congenital vessel abnormalities fit here. The trauma directly hits the external supply lines.
Makes sense. Trauma disrupting the pipes, essentially.
Exactly. Third, we have extraosseous venous issues. Here, it's not the inflow, but the outflow that's the problem. Impaired venous drainage leads to congestion, increased pressure inside the bone, which then compromises arterial inflow. Think venous abnormalities or stasis.
Right, like a plumbing backup causing pressure.
Precisely. Fourth is intraosseous extravascular compression. This is about pressure building up inside the bone marrow cavity itself, squashing the small vessels. Bleeding within the bone, hemorrhage, can do this. Elevated bone marrow pressure is a key concept here. Also, fatty infiltration, often linked to high-dose steroid use, where fat cells enlarge and increase pressure. Conditions like Gaucher disease causing marrow infiltration or simply bone marrow edema. Even displaced fractures compressing the internal space.
So internal pressure squeezing the vessels from the outside.
Correct. Fifth is intraosseous intravascular occlusion. This time, the blockage is inside the vessels within the bone. Things like coagulation disorders, thrombophilias making clots more likely, or hypofibrinolysis where clot breakdown is impaired. And, very importantly, sickle cell crises, where the sickled cells physically block the microvasculature.
Direct blockages within the pipes themselves.
Yes. And finally, the sixth category is multifactorial causes, where it's a mix of these things or perhaps factors we don't fully understand yet. And it's worth remembering that in about 25% of cases, we actually label it as idiopathic. We just can't identify a specific cause. Think Kienbuck disease in the wrist or Preiser disease.
That framework is incredibly helpful for organizing what is, as you said, a bewildering list. Could we delve a bit deeper into some key causes we commonly see in orthopedics? Corticosteroids, for example. They're used so widely. How exactly do they cause AVN, and what should we be thinking about?
Corticosteroids are definitely a major player, especially high doses used over prolonged periods. The precise mechanism is still debated, which is part of the challenge, but the leading theory involves inducing osteocyte apoptosis, programmed death of those vital bone-maintaining cells. This messes up the lacunar canicular system, that microscopic network delivering nutrients within the bone. If that breaks down, the osteocytes effectively starve.
And is it the total dose or the peak dose that matters most?
That's the debate. Is it the peak dose or the cumulative total dose? Generally, sustained high doses over weeks or months are considered more problematic than, say, short, sharp bursts. Other proposed mechanisms include fat accumulation in the marrow adipogenesis, leading to that intraosseous hypertension we talked about, physically squeezing vessels. Steroids might also promote a hypercoagulable state, causing tiny clots within the bone's microvasculature. There was a significant long-term study by Hernigou looking at shoulders. It found that 65% of initially asymptomatic shoulders develop pain, half experienced collapse, and half needed surgery within 15 years. It really highlights how progressive and silent steroid-induced AVN can be.
That's a very sobering statistic. A real warning. What about trauma? That seems like a more obvious direct insult to the blood supply.
Trauma is certainly a direct and very significant cause, particularly in joints with a known precarious blood supply, like the humeral head or the talus. Severe fractures or dislocations can physically tear, stretch, or compress the delicate vessels supplying the bone. For instance, with humeral head AVN after trauma, the rates can be alarmingly high. 4-part fracture dislocations. Risk approaches 100%. Displaced 4-part fractures, maybe 45%. Even 3-part fractures, around 14%.
Wow, those are high numbers.
They are. And it's not just if it's fractured, but how. Work by Hertel and others showed the specific fracture patterns, the combination of fracture lines, and whether the medial hinge is intact are all critical factors influencing the risk of the blood supply being compromised. The more disruption to that vascular architecture, the higher the AVN risk.
Okay, and sickle cell disease. Given its prevalence in certain populations globally, that must be another major factor.
Absolutely. Sickle cell disease is a huge contributor worldwide, especially in places like sub-Saharan Africa and India. The core issue is the abnormal sickled shape of the red blood cells. These rigid, crescent-shaped cells don't flow well through tiny capillaries. They get stuck, causing microvascular occlusion blockages. This leads directly to tissue ischemia and infarction in the bone.
So the bone tissue just doesn't get enough oxygen.
Precisely. Shoulder osteonecrosis is particularly common, seen in up to half of patients with certain hemoglobinopathies, and it's often bilateral in these individuals, affecting both sides. That points to a systemic issue. Poignard and Hernigou's study tracked symptomatic humeral head AVN in adults with sickle cell. They found an 86% collapse rate over 20 years. It underscores the relentless progression in this group. Managing AVN in these patients is also complicated by their underlying condition.
And alcohol misuse, another common factor we encounter, what's the connection there? Is it dose-related?
The link between chronic, heavy alcohol use and AVN is well established, though the exact mechanism is, again, a bit elusive compared to direct trauma. Animal studies suggest alcohol might increase intraosseous pressure and promote adipogenesis, that fat accumulation in the marrow. This internal pressure could then compromise microcirculation. There does seem to be a dose-response relationship. More chronic, heavy drinking increases the risk, but a clear threshold isn't definitively set. It's likely a combination of factors: direct effects, altered lipid metabolism, perhaps genetic susceptibility, and other issues often linked with alcohol misuse.
Right. Now, dysbaric osteonecrosis, or Caisson's disease, that sounds quite specific, an occupational hazard almost. Tell us about that and the role of a PFO.
Yes, dysbaric osteocrosis is fascinating. It mainly affects people exposed to rapid pressure changes, professional divers, compressed air workers, like those in tunneling. The mechanism involves nitrogen gas dissolving into tissues under high pressure. If decompression is too fast or inadequate, this dissolved nitrogen forms bubbles as the pressure drops. These bubbles can form in the blood and, crucially, lodge in the microcirculation of bone.
Like the bends, but affecting bone.
Exactly.
Yep.
And what's really critical and perhaps less appreciated is the role of a patent foramen oval, or PFO, that small hole between the heart's upper chambers some adults have. If a diver has a PFO, their risk of decompression illness, including AVN, can increase significantly, perhaps up to 5 times. It allows venous blood, potentially saturated with nitrogen bubbles, to shunt directly into the arterial system, bypassing the lungs' filtering effect. These bubbles then go straight to tissues like bone. It really highlights why asking about diving or pressure exposure history is important.
That's fascinating. Beyond these major players, are there other factors worth keeping in mind? The list seems quite long.
It is quite extensive. A few others to mention: repetitive microtrauma, maybe from certain types of manual labor or sports. Radiation therapy can damage bone vasculature. Hyperlipidemia, high blood fats, might contribute to vessel blockage. Autoimmune diseases like lupus are linked, both due to the disease itself and often the steroid treatment used. And then, as we said, there's that significant chunk, about 25%, where it's idiopathic, no clear cause found, like in Kienbuck's or Preiser's disease and the rest.
It's clear the causes are incredibly diverse. Let's shift now to how patients present. You mentioned earlier the challenge of asymptomatic early stages. That silent nature must make early diagnosis really difficult. What are the typical symptoms we should be listening for, and what history points are vital to gather?
That's a key issue. The insidious onset often leads to diagnostic delay, which impacts outcomes. For non-traumatic cases, the typical presentation is mechanical pain. But its onset, severity, location, it can all be quite variable. Often a dull ache, sometimes sharp, often poorly localized, maybe radiating. And critically, in those early stages, the physical examination is usually entirely normal. Full range of motion, no swelling, maybe vague tenderness at best. This clinical picture, or lack thereof, is a major reason for delayed diagnosis. Clinicians might initially dismiss it.
So if the exam is often unhelpful early on, getting a meticulous history becomes even more critical. What specific things should we be asking about?
Absolutely crucial. You need to delve deep. Ask about any recent significant trauma, even if the patient downplays it. Detailed steroid history is vital: dose, duration, why they took it. Many patients don't connect the dots. History of autoimmune conditions like lupus, sickle cell disease, ask specifically. Chronic alcohol intake and smoking history need to ask directly, as they're often underreported. What about their occupation? Any manual labor involving repetitive joint stress? Ask about any subtle changes in gait, any insidious pain that seems out of proportion, any reported decrease in movement, and don't forget connective tissue disorders or known clotting issues.
Okay, let's break it down by site, as the presentation can differ. The hip being the most common, what's the typical picture there when symptoms start?
With the hip, yes, often asymptomatic initially. When symptoms appear, it usually means things have progressed. Patients typically report hip or groin pain, often deep and aching. You refer to the buttock, thigh, even the knee, confusing things. Pain at rest, and especially night pain disturbing sleep, is quite common and a bit of a red flag. Stiffness is another complaint, particularly after sitting. And as it advances and the head starts to collapse, you'll see gait changes, a limp. Often loss of internal rotation is one of the first objective signs we pick up.
And the knee, you mentioned sunk spontaneous osteonecrosis of the knee. That sounds like it presents differently.
SONC does, yes. It predominantly hits the medial femoral condyle, maybe 94% of the time. The presentation is typically quite acute, sudden onset knee pain, often sharp. It's worse with weight bearing, but notably can also occur at night. There's often an underlying history of osteoporosis or osteopenia, but usually no recent trauma. That helps distinguish it. On examination, you'll find tenderness right over that medial femoral condyle, and often reduced range of motion due to pain. It's classically seen more in women, maybe in their 60s or older.
What about the shoulder, the proximal humerus? How does that present, especially given the trauma link?
Shoulder AVN often presents more insidiously. Gradual onset of shoulder pain over weeks or months, maybe without a clear trigger, although trauma is a major risk factor, as we noted. The pain is often described as deep, aching, sometimes pulsating, perhaps radiating toward the elbow. Patients will report a progressive loss of active movement, especially reaching overhead or across the body. It's also frequently associated with AVN elsewhere, suggesting a systemic issue or that history of significant trauma like a fracture dislocation. The rotator cuff is usually okay, which helps differentiate it from cuff problems, but that deep bone pain is key.
And the talus in the ankle, particularly after injury.
Talus AVN is strongly linked to trauma, especially displaced talar neck fractures and sometimes polyarticular disease. Patients complain of persistent, deep ankle pain and difficulty walking, often lasting much longer than expected after an injury. There might be ongoing swelling or stiffness. The talus is vulnerable because so much of it is covered in cartilage, limiting areas for blood vessels to enter, making its supply quite tenuous after a fracture disrupts things. Finally, the wrist keen bucks affecting the lunate, prisers affecting the scaphoid. What's the story there? Yes, these are specific entities. Often patients present without a clear history of major trauma, which can be misleading, hence the idiopathic label sometimes. It's often skilled manual workers, middle-aged males for prisers sometimes. They typically complain of one-sided wrist pain, usually dorsal and radial. They'll also notice decreasing wrist movement, maybe some swelling over the affected bone, and reduced grip strength. Again, catching these early is key to try and preserve wrist function before collapse occurs.
It's clear clinical suspicion driven by history is vital, but imaging seems absolutely critical for confirmation and, crucially, for staging to guide treatment. Can you walk us through the imaging tools and how they help us stage the disease?
Imaging is indeed indispensable. We usually start with plain radiographs, typically 2 U's at right angles. They're the standard initial test, but the big limitations, they're often completely normal in early AVN, sometimes for months. Later on, you might see osteolytic lesions, areas where bone is being resorbed, or sclerosis. The key sign, particularly in the hip and shoulder, is the crescent sign, that thin, dark line just under the joint surface. That indicates a subchondral fracture or early collapse, meaning the disease is already quite advanced.
So x-rays are useful later, but for early detection, what's the go-to? The gold standard?
For picking it up early, especially if x-rays are clear but you're suspicious, MRI is undoubtedly the gold standard. It's highly sensitive to those early bone marrow changes. We look for specific things. Osteosclerosis, yes, but crucially that increased T2 signal and decreased T1 signal reflecting the marrow edema or ischemia. The classic finding is often described as a double-line sign. A band-like area, dark on T1, bright on T2. That's considered almost pathognomonic. MRI's sensitivity for early detection, say in the shoulder, approaches 100%. It's essential.
Are other scans like CT or bone scans ever useful?
Yes, they have roles. CT scans give excellent bony detail, so they're helpful if you suspect a subchondral fracture that's maybe not clear on MRI, or for accurately assessing the extent of collapse for surgical planning. Radionuclide bone scans using technetium 99 meters show areas of altered blood flow and bone cell activity. They can be useful, perhaps in looking for disease in multiple joints, but they're generally less sensitive and specific than MRI for early localized lesions. They show metabolic activity rather than fine anatomical detail.
Once you have the diagnosis via imaging, staging becomes the next critical step for prognosis and treatment planning. Can you outline the key staging systems for the main joints? Focusing on their clinical relevance might be helpful, as there are quite a few.
Absolutely. Staging is fundamental because treatment options change dramatically depending on the stage. For the hip, the Fickat and Erla system is a classic 4 stages based on x-rays, from normal x-ray, stage 1, to collapse and arthritis, stage 4. The Steinberg classification is also common and importantly incorporates MRI to quantify lesion size, especially in pre-radiographic stages, stage 0Y. This helps identify candidates for joint-preserving surgery earlier. For the knee, Camilo-Sung, the Cochino classification tracks progression through 4 stages, again starting with clinical symptoms, MRI changes, but normal x-rays, stage 1, moving through sclerosis and flattening, the end-stage degenerative changes, stage 4. In the shoulder, humeral head, the Cruz classification is very useful because its 5 stages directly correlate with treatment options. Stage 1, normal x-ray, MRI, changes only. that T1 dark, T2 bright signal. Stage 2. X-ray shows sclerosis or maybe some cysts, but importantly, the head shape, the sphericity, is maintained. This is a key stage for potential joint salvage. Stage 3. You see the crescent sign, the subchondral fracture, maybe minor surface depression. Collapse is imminent or starting.
Stage 4. Definite flattening and collapse of the humeral head. Underlying bone structure looks abnormal, maybe loose bodies. Stage V has progressed to involve the glenoid as well, so full glenohumeral arthritis. End-stage disease.
That's very clear how the Cruz stages guide treatment. What about the talus and wrist?
For the talus, especially after neck fractures, the Hawkins classification is key. We look for the Hawkins sign on X-ray, that subchondral lucency indicating blood supply is returning. If it's absent at 6 to 8 weeks, that strongly suggests necrosis and is a poor sign. For the wrist, in Kienbuck's lunate, the Lichtman system has 4 stages. Stage 1 is normal X-ray. Stage 2 shows sclerosis. Stage 3 involves lunate collapse and carpal instability. Stage 4 is widespread wrist arthritis. For Prizer's scaphoid, the Herbert and Lanzetta classification tracks progression similarly, from early changes in the proximal pole to eventual carpal collapse.
So it really is a combination of the patient's story, the exam, and then interpreting these sophisticated images within specific staging frameworks to plan effectively.
Precisely. Imaging is crucial, but the diagnosis remains clinical at its heart. You need to synthesize the history, the exam findings, and the imaging interpreted through these staging systems to get the full picture and decide on the best management for that individual patient.
Okay, having covered diagnosis and staging thoroughly, let's pivot to treatment. AVN presents this wide spectrum of options, from doing very little surgically to major joint replacements. Choosing the right path seems critical. Can you outline these approaches and their indications?
Certainly. The core principle is that treatment depends heavily on the stage. Early intervention, aiming for joint preservation, generally gives better results. But as we've said, the challenge is often catching it early due to the lack of initial symptoms. The goal is to prevent collapse if we can, or manage the consequences if we can.
So what's the first line of attack, particularly in early stages or for non-surgical candidates? What does conservative management involve?
Conservative management is often the starting point for very early small lesions, or for patients unsuitable for surgery. It includes several components. Pain control, using NSAIDs primarily for pain and inflammation. Opioids might be needed for severe pain, but cautiously. Physical therapy, this is really important. Structured programs to maintain range of motion, strengthen surrounding muscles, to improve stability and potentially offload the joint, and improve overall function, coordination, balance. For hip knee, maybe gait training. Activity modification, absolutely crucial. Patients need to reduce mechanical stress on the joint. Limiting overhead work for shoulder AVN, perhaps partial weight bearing with crutches for hip or knee AVN. Reducing impact. Bisphosphonates. These are drugs that slow bone resorption. Their use in hip AVN is a bit controversial. Results vary. However, for SOC in the knee, they have shown clear benefit, significantly reducing the need for surgery in some studies by delaying that necrotic bone resorption and subsequent collapse.
Right, and if conservative steps aren't enough, or the disease is slightly more advanced but hasn't collapsed yet, we move to joint-preserving surgery. What are the options there?
It's exactly. If feasible, and crucially before significant collapse, joint-preserving surgery aims to save the native joint. Key options include core decompression. This is fundamental. We drill into the necrotic bone to relieve pressure and hopefully stimulate blood flow and healing. It's best for early stages, Cruz the third in the shoulder, pre-collapse hip, and smaller lesions. Often combined with injecting bone graft or bone marrow aspirate into the channels to boost healing. Some evidence suggests it works better if there's venous congestion. Bone grafting. Replacing the dead bone with healthy bone, either autograft, patient's own, or allograft donor. Often done alongside core decompression. Sometimes vascularized grafts are used transferring bone with its own blood supply, but that's more complex. Rotational osteotomy, mainly for the hip. If the lesion is localized, you can surgically rotate the femoral head to move the bad bit out of the main weight-bearing zone. Can have high success rates, but it might make a future hip replacement more technically difficult. High tibial osteotomy. For SONC in the knee, if there's also a significant malalignment.
Realigning the tibia shifts load off the affected medial side. Autograft transfer, OATS. Also for the knee. Moving plugs of healthy cartilage and bone from a non-weight-bearing area to fix a contained defect and pre-collapsed alone, like a small resurfacing patch.
And when those preserving options aren't suitable, or the disease is just too advanced with collapse, it's joint replacement time. What does that look like for the different joints, keeping in mind these patients are often younger?
Correct. When preservation fails or isn't possible due to advanced disease, significant collapse, large lesions, then arthroplasty or joint replacement is the mainstay. For the hip, total hip arthroplasty, THA, gives excellent pain relief and function. Usually cementless implants are preferred, especially in younger patients. The big concern, though, is implant longevity. Younger, more active patients have higher rates of wear and osteolysis over time, potentially needing revision surgery later. Hip fusion arthrodesis is very rare now, maybe only for young, heavy laborers. For the knee, if it's localized SOC in an older patient, a unicompartmental knee replacement, UKR, can work well. For larger lesions or more general arthritis, it's a total knee replacement, TKR. In the shoulder, for moderate disease, Crucis 3 with enough good bone left, humeral head resurfacing or a hemiarthroplasty might be options. For advanced disease, Crucis V involving the glenoid is usually a total shoulder arthroplasty, TSA. Again, longevity in younger patients is a concern. If the rotator cuff is also severely damaged, a reverse shoulder arthroplasty might be needed. Infection is an absolute contraindication.
For the talus, the key is good initial fracture fixation to prevent AVN. If it occurs, surgery tends to work better in younger patients. And the wrist. For Kienbuch's, early treatment might involve bone grafts or offloading, splinting. Later stages with collapse might need procedures to stabilize the carpus, like radial shortening, or salvage procedures like fusion, or removing the proximal carpal row. For prisers, similar early options, but later stages often need surgery, like scaphoid excision, carpectomy, or fusion. Surgery is often unavoidable eventually.
It's certainly a complex decision tree, highly individualized. Let's turn now to the longer-term picture. Prognosis, complications, and the importance of a team approach. What is the typical outlook for AVN patients, and what challenges or complications might they face?
The prognosis, unfortunately, is often quite poor overall. Regardless of initial treatment, there's a high likelihood of progression, leading to persistent pain, disability, and joint destruction, often culminating in arthroplasty. Mont's study found nearly 60% of asymptomatic lesions became symptomatic or collapsed. For the humeral head, some studies show up to 80% eventually needing replacement. So once it starts, it tends to keep going. Prognosis is better if diagnosed early, and if collapse is minimal, less than 2 millimeters seems a key threshold for the hip.
That's a tough outlook. What about complications, especially after surgery?
Well, you have the standard post-op risks. Infection, implant problems like loosening or dislocation, nerve or vessel injury. But specific to AVN treatment, failure rates can be high. Core decompression for hip AVN, for example, fails to halt progression in a large percentage, maybe up to 90% in some series, especially if done too late or for large lesions. And there are procedure-specific things, like causing ulnar-sided wrist pain after a radial osteotomy for Kienbuch's if the alignment isn't spot on. Meticulous technique is vital.
And how do underlying health issues, comorbidities, affect things?
Hugely significant. Patient comorbidities drastically impact complication rates and recovery. Take sickle cell patients needing joint replacement for AVN. They have longer hospital stays, higher risk of kidney injury, implant failure, blood clots, DVTPE, heart attack, and higher mortality compared to non-sickle cell patients having the same operation. It really drives home the need to assess and manage the whole patient, not just the joint.
Given the often silent start and relentless progression, what about prevention or patient education? Can we mitigate risk or encourage earlier presentation?
That's critical, because it starts silently but progresses. Reducing modifiable risk factors is key. Avoiding excess alcohol, stopping smoking completely, managing steroid use carefully, lowest dose, shortest time, consider alternatives. Lifestyle helps too. Healthy weight reduces joint stress, ergonomic adjustments for manual work, and encouraging proactive health checks might help pick up risk factors or early signs before they become debilitating. Raising awareness among patients and primary care is important.
And finally, Professor, thinking about the healthcare team, AVN poses this diagnostic dilemma. How can an interprofessional approach improve outcomes here?
It presents a huge dilemma, often leading to late diagnosis and limited options. While the orthopedic surgeon usually manages the definitive care, educating everyone at the front door is vital. GPs, A&E doctors, physios, nurses. They might see those early vague symptoms. A truly well-functioning interprofessional team is the ideal. Rheumatology input for autoimmune links, hematology for sickle cell, pain specialists, everyone contributing their expertise. Crucially, this requires excellent communication within the team and meticulous documentation. This ensures everyone is on the same page, changes are spotted early, and the right care is delivered promptly. That collaborative, holistic approach is, without doubt, what gives patients the best chance against this challenging condition. It really does make a difference.
Professor, this has been an incredibly thorough and truly insightful deep dive into avascular necrosis. We've covered the fundamental science, the complex causes, the subtle presentations, the nuances of diagnosis and staging, and the wide spectrum of treatments. Your expertise has been invaluable in shedding light on this. We've heard today how relentless avian progression can be once it becomes symptomatic. It leads me to wonder, beyond managing individual patients, what systemic changes could we, as a medical community, consider to really improve early detection, particularly for high-risk asymptomatic groups? How might we shift focus towards prevention or earlier intervention? Something for us all to think about. If you found this deep dive valuable, please do rate and share the show to help us reach more professionals like yourself. Thank you for joining us on The Deep Dive.